Welcome everyone, thanks for joining us today. Today I'm chatting with Jessica Poval. Jess, I'm going to let you introduce yourself, and today's topic will be about concussion. So I thought we'd dive into this topic for concussion. It's something we haven't spoken about on this podcast before, and I think it's something that all of us come up against at some point in our clinical practice, and something we should be aware of, not just the signs and symptoms, but potentially how to manage, co-manage or refer if need be. And I know this is an area of special interest of yours. So thank you for joining us today to chat about concussion. Just tell everybody who you are, where you're from, and what you do.
Thanks, Shaun. Really appreciate it. So my name is Jessica Poval, and as Shaun said, I'm a physiotherapist. I work in Gladesville in North Sydney. I work at a clinic called Brain Hub, and I work with a team of chiropractors and occupational therapists for the treatment of a lot of different conditions, one of which being concussion. And so I did my training in the US and moved to New Zealand. I lived there for about 12 years, and just my career pathway took me to Sydney, and I'm really fortunate to have the opportunity to work here in Australia now.
Perfect. Well, thank you. And thank you for coming to our country and sharing your knowledge and skills over here. So tell us a little bit about, first, let's start with the pathophysiology of concussion. Tell us what it is. I know there's a lot of people out there. We've all heard of concussion. We've all either had one or know somebody who's had one or see patients with them. But I don't think many therapists actually understand what's actually taking place with the pathophysiology.
Yeah, indeed. I know there's you're right. I don't think a lot of people understand the pathophysiology of concussion. So I always like to say a knock to the head is not simply just in the head. So it has a full body effect. The pathophysiology of concussion starts really locally in the brain and in the gray and the white matter. So it's actually a shearing injury between the neurons of the gray and the white matter. So while white matter and the gray matter, they both have different densities. So when we do sustain a force to the head, this movement causes this stretch and pull of the axons within the brain, and this creates that chemical cascade of inflammation. This usually kicks off with the microglial cells, which are kind of the immune gatekeepers of the brain, and they're the first responders to any kind of brain injury. So following a concussion, these microglial cells trigger what we know as the cytokines, which help launch this really local inflammatory response within the brain. But like I said, a knock to the head doesn't just stay local to the head. It actually triggers this full body immune response, which actually spreads further down even to the gut. So we know that this inflammatory process starts in the brain, travels via the gut-brain axis to the microbiota of the gut. And it's been shown that the activation of the immune system can trigger events such as changes in the permeability of the gut as well. And this happens within hours of that initial injury. So we know that within the first 6 hours, up to 7 days, that person will experience quite a bit of activity in the immune system in the gut, and that change in the permeability, which the more we learn about the gut, we know that it's the little brain or the second brain. And so we know that there's such an effect systemically on this.
Is the connection between the brain and the gut a fairly new understanding when it comes to concussions? Because it seems to be a hot topic, or has been for a couple of years now. Yeah.
Definitely. Yeah, absolutely. And I guess we used to really focus on that coup contra coup injury. So it was just that shaking, if you will, of the brain. But we know it's so much more sophisticated than that now. The body is so intertwined with all of these systems. So yeah, it cannot just be localized in the head. And yeah, you're right. The more we learn about the gut, the more we realize we really underestimated how powerful it is.
And the management then, I don't know, I'm skipping forward. We'll come back to the management in more detail a bit later, but does the management take place in the gut as well as what we do with the brain? Is that an approach that we look at? Yeah.
Absolutely. As clinicians, we're not helping our patients fully if we don't address other things like inflammation and education around, okay, what you put in your mouth actually really impacts your recovery, especially in those first couple of days following concussion.
Interesting. Yeah, right. And I know that people go through concussion have different phases when it comes to symptoms and their experience of it. And it can change from the first few days to then what happens, days and weeks later. Can you talk a little bit more about that?
Yeah, absolutely. So the two stages that happen with concussion. So the first one is this excitatory phase. And so at the time of that initial injury, we have these chemical reactions that are happening really locally and cellularly in the brain. And most of us have watched sport at some point, and you see someone who's taken a hit and it's a pretty significant hit, and you'll see maybe they look confused, they're stumbling, they've got this slurred speech, they just don't look right on the pitch there. We may have seen someone who's actually lost consciousness, which again it's a lot more rare than people think with concussion. We used to think that, oh, if you lost consciousness, that's the cardinal sign, but it's not. In fact, less than 10% of people who have a concussion actually lose consciousness. So that's not a good indicator of what's concussion or not. But yeah, especially during that initial phase, we'll see all these signs initially right then and there. But the second phase of concussion is that spreading or that depression phase. And that's when patients that we tend to see will present in clinic with that ongoing headache, fatigue, poor concentration. They can start to develop things like anxiety, a bit of depression, these severe mood changes that they may or may not have ever had before, sleep issues, visual changes, all of those symptoms. Right. So those two phases really work together. It kicks off initially, but then it's the aftermath that we're trying to manage clinically.
Yeah. So many of those symptoms, those clinical features, can be present with other presentations, other conditions. So as a clinician, when you're going through your differential diagnosis, obviously there's a moment in time, most likely, where they had a knock to the head or a fall or something like that. A concussion would seem obvious. But what are some of the other things that might be misdiagnosed as a concussion? It's actually something else.
Yeah, absolutely. So, anxiety, it's so prevalent these days. We see it with all different walks of life, and so many people are carrying it with them. I think that's one I see a lot that clinically gets misdiagnosed, or people assume that, oh, they had something happen to them. Maybe my anxiety is just a little flared up this week. But we know that actually the effects of concussion can really have this effect on any pre-existing mental health. I think fatigue as well. People sometimes just assume, oh, I bumped my head, it's fine. Maybe I'm having a tough week, but they can really kind of brush over it in terms of the severity of those symptoms.
Right. Yeah. And so then, obviously, we work through our differential diagnoses and we come up with this idea that, yes, it's most likely concussion. But what's the best sort of line of assessment that we conduct as a clinician to determine if we actually do have concussion and what the fallout of that might be?
Yeah, absolutely. So if someone does present and you suspect they've had a concussion, I guess do a really thorough history. We've all bumped our heads on things before, and it actually doesn't take as much as you think for people to have these ongoing symptoms. So if there was an event, like one I've seen really commonly is people with young kids, the kids bump into them, they're holding their kid, the kid bumps their head or whatnot. And don't just brush it away. Just, if there is something like that there was an event and you have symptoms following it, that's actually the diagnosis of concussion. So an event that we can definitively say, this happened on this day, and you're having at least one symptom, then it is suspected concussion.
Gotcha. Yeah, right. And then so as we go through assessment, there's obviously different components to this, right? There's different parts. You mentioned before things like balance and vestibular effects. And what are some of the assessment protocols we look at for those?
Yeah, absolutely. So one of the things I do initially when someone comes into the clinic is I want to test, as you're saying, you want to test visually. How are they doing? A lot of people struggle with things like screens. They struggle with reading, and that's just the changes that happen in those oculomotor processes following concussion. So the brain controls the eyes, and if there is a little bit of a delay or a mismatch in communication between what the eyes are taking in and what the brain is interpreting, then people will struggle with these day-to-day tasks. You mentioned vestibular. That's one thing we want to screen right away as well, in terms of, can we help this person in that first session? So are they experiencing any peripheral vestibular issues? So BPPV is a common one that turns up after concussion. People also have centralized vestibular issues as well. So again, that mismatch in communication between what the vestibular systems are interpreting and how the brain is relaying that information and making sense of that world around us. So if there's something we can do in that first session to help someone feel less dizzy and a little more centered and balanced in the world around them, then low-hanging fruit, we can address that quickly. One of the other things that is an absolute must when someone comes in is looking at the neck. So we know that any head injury will have an element of neck injury to it as well. It's impossible for the forces that have gone through the head to not impact the neck. And I guess one thing with concussion as well, we think the head has to contact something, but it doesn't. So like with motor vehicle accidents and whiplash injuries, those cause concussion as well. sometimes nothing has hit the actual cranium itself. So looking at the neck, we know that those forces reverberate straight through the neck too. So we need to screen for instability. Are they experiencing any element of whiplash? And that layering of whiplash and concussion, it's so intertwined. We often treat them very similarly. On the topic of the neck, if anyone has any instability or you're suspecting a fracture, that's priority number one. Get it looked at, refer out, get the appropriate scans done, just from a safety measure.
Yeah.
Yeah.
Cool. So there's an area of interest of mine, it's TMJ. Talk to me about TMJ and concussion, the link between those two things, if you could.
Yeah, absolutely. So we know that the jaw and the neck and the head, they're so intertwined. So the position of the head and the position of the neck and the jaw, it's impossible to really address one without the other because they must fit together. A lot of people with concussion, you'll see that they actually have jaw injuries following this, whether they took an impact somewhere on the front aspect of the head, whether their teeth hit together, on impact, even like we were saying in a motor vehicle accident where people don't necessarily contact their head to the surface sometimes, they still have that same force that goes through the jaw. So do we need to look at, all right, the health of the teeth, health of the jaw, but beyond that, the musculoskeletal side of it, is there any imbalances with those muscles, and how are they carrying the jaw and the neck, and what can we do as Myotherapist to address that as well? So yeah, definitely, really important.
Okay. And so once we've screened all of these things and we go, yes, I think we've got a concussion, there can obviously be different degrees of severity, right?
Yeah.
And then how does that play out for us clinically if we've got a more severe versus less severe? What's the process for us then as a clinician?
Yeah, absolutely. Great question. So what we know about concussion, or otherwise abbreviated as mild traumatic brain injury, MTBI, we know that they do recover. So the literature does support the fact that almost all concussions will make a full recovery if they're in the mild range. Moderate and severe, we use scales such as the Glasgow Coma Scale. So these are ones that are often done at the hospital at the time when people turn up having had a concussion, and these will know, their level of responsiveness, pain, what was their consciousness level at the time of the injury. We use that Glasgow Coma Scale to decide sometimes if someone's had a mild, moderate, or severe concussion. More on the moderate to severe, we know that we're dealing with, these are the ones that will turn up with bleeds to the brain, things that are a little bit more structurally impaired that we can detect on a scan. That's obviously a little bit more of a journey in terms of recovery. For those who've had a mild concussion, nothing will generally come up on a scan. So a lot of people will wonder, why didn't I get a CT or an MRI following this? If you don't get referred for one, it's not worst case scenario. A clinician probably has screened for all those red flags. And we also know that, if we do send people for unnecessary imaging, it doesn't always show things anyways. So it's more in that moderate to severe that we start to see those structural changes on scans.
Okay. And then what about our education post-assessment and treatment? How does that, what does that involve as a clinician? What sort of education should we provide?
I think education is one of the first things we need to do. So when someone turns up in the clinic after we've done our tests and we've screened things, we have a really good opportunity to educate them on concussion recovers. We know you can get better. We know it feels terrible at the time, but we can walk through things clinically and help that person get better. I think it's really important to help people set their expectations on that, because everyone knows someone who's had a concussion and it's gone pear-shaped and it's not gone the way they wanted it to. And I think the general public has this misunderstanding that concussion is one of those things you get on a Saturday night and by the next weekend you're fine and you can play sport again, but that's not really the case. It can take a while. So it's setting that expectation of, okay, you will feel a bit rough, but if we do some education of pacing, doing things little and often with some breaks, how do we adjust your environment? How do we minimize screen time in the first couple of days? How do we gradually re-expose the body to these things? That's really important. One element of education I always like to use as well is exercise. So one test that called the Buffalo Concussion Treadmill Test is the gold standard in activity tolerance testing. So it's a great test that looks at the autonomic nervous system and the body's ability to shunt blood to the brain while we're exerting ourselves. with this, if the person's able to tolerate it, I'll do it as soon as possible. So the literature supports you can do this test within 2 days of a concussion. So this involves putting someone on a treadmill at a steady state of walking and gradually increasing the incline while you're monitoring their symptoms, their heart rate, and how hard they feel they're working. So RPE or the Borg scale. And using those numbers, that guides you in terms of, all right, do they have a true activity intolerance? Or are they experiencing an autonomic nervous system issue or a blood flow issue to the brain? And if they are, the answer is we gradually work them up with exercise. So I guess setting that expectation with education that, yeah, exercise is key for recovery as well. A lot of people think that they need to rest and not do anything that's provoking their symptoms. But we actually know now that that just lowers the body's threshold for the tolerance to daily activities. And the goal isn't to lower your lifestyle to the point where you have no symptoms. The goal is to help the body meet the thresholds of where you were pre-injury.
I understand, yeah, right. You mentioned pacing before, which I thought was an interesting way of putting it. So we often use this term graded exposure. Is that the same thing? Is that what we're talking about?
Similar, yeah, graded exposure. So just helping someone gradually increase the level of activity. But yeah, pacing, sometimes I'll use this in terms of talking to someone around a return to work program, or how do they gradually pace themselves with work tests. So for example, if someone spends 8 hours a day in front of a screen, we might break that down and say, all right, maybe you do 1 hour, then you take 5 or 10 minutes break, get away from the screen, get some natural light, then go back to it. So pacing yourself. And I'll often use the analogy of, we wouldn't say go run a marathon tomorrow if you're not a runner. How do we work our way up to it? Maybe we need to start at 1K with a break and do it and so forth. But yeah, just pacing as you would any other activity that you were trying to build up to.
Sure. And that would go for any of the symptoms that they might be trying to manage or any of the activities they're struggling with, you just a little bit at a time. And is that sort of key component of the treatment, is just this sort of gradual reintroduction of load, in another way of putting it, I guess?
Yeah, absolutely. I'd say the one key one to be mindful of is dysautonomia or POTS. So that's a really clinically specific type of activity intolerance following concussion. So we know that when people have a dysautonomia or a mismatch in what the autonomic nervous system is sensing and how it's relaying that information to the heart and lungs, we know if people aren't responding well, or they're having a mismatch in their vitals with activity, then we need to go a little bit slower with that. So for example, if you did, say, the Buffalo concussion treadmill test and you found that someone had a really low tolerance for exercise, we would gradually work them up in a sub-threshold way. So I would go a little bit slower with someone who is struggling with activity. POTS, as I mentioned, which is postural orthostatic tachycardia syndrome, which happens in about 13% of concussion cases, a little bit more common with young females. With these patient populations, we need to go slowly with this. So that would really be quite a slow-paced progression of activity. I guess while we're on the topic of POTS, it's worth noting that only a cardiologist can formally diagnose POTS. But clinically, if we suspect it, we can do, if you work in a clinic, I'm lucky to work in a clinic at Brain Hub where we've got a tilt table where we can test for this. But also you can do the supine sit test as well. And if you're suspecting that they're really not responding with their heart rate and their blood pressure, then send them off to cardiology, get that formal diagnosis of POTS.
Sure. Okay. And so with all this information, which is fantastic, because I think there's so much of that most people, even in sort of basic level training of concussion, wouldn't come across that. There's a lot of depth there. Thank you. What are some of the key takeaways for people who are maybe, I guess, the average person who's working in a sporting club here in Australia, AFL, rugby, those sort of places where concussions are relatively common? I've worked in clubs like that, and I know that the level of training and education around concussions is generally pretty poor. What are some of the key things that people should sort of be looking for and taking away from this?
Yeah, absolutely. If someone sustains an injury or a hit, for example, like pitch side, if they're playing and they sustain a hit, take them off the pitch, really give them time to look at this. I mean, I know we do head injury assessments and things, sideline, but really see how are they doing. A lot of times people will be so eager to get back into the game. They just want to keep playing and they think, oh, I wasn't knocked out, it's fine. But there's a lot more to it than that. So really, taking a look, are they confused? Or how's their balance? Do they know where they are? I mean, there's some really good basic sideline tests, like the SCAT test has been around for ages. But there's more sophisticated ones out there now in terms of being able to screen, look at the eyes, look at how they're tracking. Are they physically capable of jumping back on the pitch with a bunch of other moving bodies playing a game? I think if we were to see someone clinically, just encouraging people to seek treatment early. So don't just wait a week, don't wait 2 weeks. We know that earlier intervention is key. So the sooner we can get someone assessed, the sooner we can triage them and make sure there's no red flags, and also get them started on just some basic education. Okay, maybe we drop back your screen time a little bit, maybe we adjust your routine a bit. Can we get you started on some exercise that won't be provocative for you? And how do we start treating other things like the neck? I know we talk about it a lot in terms of there's so much that happens with the neck, and can we do something hands-on to help calm that down? As a clinician, I found dry needling is really, really helpful. So through the ACE courses, through you guys, I've found that to be a real game changer in how I've addressed the neck. And yeah, just give people some general considerations for how they can support their own recovery too. So things like hydration, dietary considerations, like we talked about, just with the gut being so important.
Mm-hmm.
Being mindful of, following a concussion injury, that's not the time to have lots of caffeine, alcohol, processed food. We know that those things are really rough on the gut. And if your body's having that inflammatory response, don't fuel it with that stuff.
Gotcha. And so what happens then if the patient doesn't take our advice? They've got even a mild concussion, and we say, don't drink alcohol, don't continue to play sport, don't do it, and off they go and they do it anyway, which obviously happens, right? What's the potential fallout from this?
Oh, it's huge. It's huge. So there are studies now that show if you were to get a second concussion within that metabolic window, so the metabolic window is around 30 days. If you were to get a second hit, so second injury as they call it, then your risk of serious complications is much, much higher because your body hasn't recovered from that metabolic process. I would say as a clinician, document it. Document that you've told them, refrain from play, do not drink alcohol, don't be in these risky behaviors. If you've got someone who operates heavy machinery for a living, make sure that you're following the correct protocol. That make sure they get screened. I would get the sign off from a doctor before they jump back into this, especially if they're having balance issues, visual issues, things that would really put them at risk.
Yeah.
As clinicians, document it, advise them. Without scaring them too much, and just to help them understand that this is bigger than what we see on the outside. Concussion is known as the hidden injury. People look at you and think you're fine, but physiologically there's so much going on.
Okay. And I'm sure you've come across patients who haven't taken advice and gotten that second knock and have had those sort of longer term symptoms. What does that look like clinically when someone's had more than one, haven't recovered well, and they've had that more negative and more serious fallout?
Yeah, absolutely. So we know that their recovery will be longer because of it. We know that metabolically it does set them back. Definitely. We know that the body is then trying to fight two battles, for lack of a better term. So you haven't recovered fully from the first one, and then you throw the second one on top. Yeah, we know that the timelines will be blown out on this. And it is a lot harder. Sometimes people they develop new symptoms. So maybe they didn't have visual disturbances before. Now they're struggling with that too. So it just makes that clinical picture so much harder. Go back, retest things, but you may need to pull back in terms of what you're doing. If they were doing one level of exercise last week, this week you might need to go less. I guess on the flip side of that, you also get the hypervigilant patient who has had a concussion and then they have a slight bump to the head, whether they bumped their head on a door, cupboard, whatever, and then they assume that their recovery is going to be blown out because of that. That's not always the case either. So if you have someone who has a minor injury after that metabolic recovery window of 30 days, they may not revert back to day one.
Right.
And that's where education is really important in helping them understand that, no, it's okay. Retest, see where you're at, and then proceed.
Perfect. Jess, this is really fascinating stuff. What got you into this? Why concussions for you? That's a fairly niche, narrow sort of space to work in.
Yeah. I just always really liked neuro rehab. I worked at Spalding Rehab in Boston, and I was exposed to lots of different musculoskeletal and neuro injuries, and I felt that concussion really tied the two together. I guess I was always fascinated by the fact that I thought, when I was growing up, I thought concussion was something that athletes get, or it was really specific to a certain population. But the more I practiced clinically, the more I just saw regular people off the street getting concussions, and I just found it really interesting how it impacted day-to-day life, and just that injury that no one can see. As clinicians, we can often see the problem from a mile away because people are walking differently or holding themselves differently. But with concussion, people look fine, but they're really not fine. And I just find that whole area of practice really interesting, and my career just led me in that direction. So.
Fantastic. And so for anyone who's listening to this and thinking, I'd like to learn more about this, is there any way you'd recommend they just start? Where should they look to go and get some more information about concussion?
Yeah, absolutely. There's loads out there on the internet with this. So, the internet is full of organizations like Complete Concussion Management, but then also there's some really good practices throughout Australia as well for this. So, like I said, I'm fortunate to work at a clinic called Brain Hub in Gladesville, where if you wanted to reach out, I'd be more than happy to have a chat with anyone who is suffering from concussion. I do free 15-minute phone calls with patients as well as clinicians just to chat through any ideas. And if you're in the Sydney area or you'd like to travel there, I would be more than happy to see anyone. So, yeah.
Fantastic. Jess, this is very interesting stuff. Thank you very much for your time. I'm sure a lot of people will have taken something away from this that they can even just be aware of clinically, even if they don't use it, just to have that heightened awareness of what to look for, and then maybe refer on if it's not their area, or at least have a better ability to be able to sort of spot these things early on and maybe help more people. So thanks very much for your time.
Thank you. Appreciate it.
Great. Thanks everyone for joining us. We'll catch you on the next one.